the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
So greetings to all the PhysioTV viewers. Today we again have a very interesting session, which is kind of going to be a very relevant and a pertinent topic of carpal tunnel syndrome. And we have none other than our very well-known Dr. Altaf Warid, who's a consultant and an upper limb reconstruction surgeon at Sancheti Institute for Orthopaedics and Rehabilitation, who's going to give us this talk and is going to highlight the points from an orthopedic surgeon point of view about what is important pertaining to the carpal tunnel syndrome. Sir has passed out his MBBS in 2009 and he has completed his G Ortho in 2012. He has a DNB in orthopedics in 2014 and being a gold medalist at that. He has done a MNAMS Ortho and also has done his fellowship in hand upper limb reconstruction surgery from Gangaram Hospital in Tamil Nadu, Coimbatore. Sir will be kind of joining us, and he's been a consultant hand and upper limb surgeon in Sancheti Institute for Orthopaedics and Rehabilitation since 2018 onwards. And he has a vast experience and is going to today highlight on the carpal tunnel syndrome. Sir, passing on the session to you. Welcome, sir.
Yeah, good morning, everybody, and good morning, Dr. Sona, and thank you for that kind introduction. In the meantime, I'll start sharing my screen. Good morning, everybody, again, and so this is one of the commonest topics which we have been discussing, in the past many years, and getting in more details of actually the diagnosis, the current management, non-surgical as well as surgical management. I think most of the audiences which will be listening must be aware of this topic of carpal tunnel syndrome, which is one of the commonest compressive neuropathies which we see in the upper limb. So I'll just start with the history. Basically, it's a very old diagnosis, old term which has been coined as we go back as 1953, where Kramer et al. In his article, coined the term as carpal tunnel syndrome, which was long back, but then in again 1947 and 51, it was Brain and George Fallon which have scribed and popularized the term carpal tunnel syndrome. So just to give a brief history about this, so these were the gentlemen who basically started thinking about this, and they have coined these terms and popularized this condition. Like I just mentioned before, it's one of the commonest entrapment neuropathies of the upper limb. The other entrapment neuropathies are the radial tunnel syndrome, in which the radial nerve gets entrapped in the proximal part of the forearm, or there can be a thoracic outlet syndrome, in which the lower part of the brachial plexus gets entrapped around the shoulder, just beneath the clavicle. And there can be a cubital tunnel syndrome, which is an entrapment of the ulnar nerve, which happens around the elbow. So there are many other entrapment neuropathies as well, which are in the lower limbs. But coming on to carpal tunnel syndrome, it's one of the commonest, and the presentation is very peculiar, and the incidence is very high as compared to the other entrapment neuropathies which we see. And at the same time, there is some other conditions also which mimic carpal tunnel syndrome, which have to be kept in mind in order to get the correct diagnosis and not to, get the wrong diagnosis. We'll come to that in the coming slide. So just to give an idea, this is the commonest entrapment neuropathy, and 3.8% of general population have this, which is a very high percentage, if we see that. If we want to understand this in detail, the anatomy of carpal tunnel is very, very important. And it's the cross section at the level of the wrist around the mid carpal joint is what is very important for us. So that is the hamate bone, which is on the ulnar side, which is marked with the yellow, and that is the scaphoid on the radial side. So these are the two pillars on the on each side, which you can call it radial or ulnar. That is that forms the two adjacent poles, you can call it, and then the floor is formed by the roof of the carpal bones. You can see it's a bony floor, which is formed by which forms the floor of the carpal tunnel. And this green thing is the transverse carpal ligament. That is what forms the roof. So this is how it's a osteoligamentous tunnel, you can call it. It's surrounded by bony borders on the three sides, and on the top of it is the roof, which is formed by a ligament, which is known as a transverse carpal ligament. And the structures which are inside are the contents of the carpal tunnel. The brown ones which you see are the long flexors of the fingers, and this is the median nerve, which is located in between the flexor tendons and the flexor retinaculum. So it's a pretty tight canal. There are a lot of studies have been done. Even we are part of one of the multicentric study, which studies the anatomy of the carpal tunnel. It studies the structure of the carpal tunnel, because there have been a lot of variations as well in the bony structure, and they also account for the incidence of developing a carpal tunnel, in such patients. So why is it important? What happens if there's a carpal tunnel, there's a compression in the carpal tunnel? So coming, just staying on to this slide for a couple of more minutes, because this is important, is that anything which causes a compression of this nerve in the carpal tunnel causes carpal tunnel syndrome. And that's what we are going to talk about. So if this is a closed compartment, and anything which increases the volume of this tunnel will lead to compression of the nerve. So most sensitive structure in this tunnel is the median nerve, and the other are the tendons, which will hardly have any effect, any symptomatology, if there is a compression of the tendon. So that is not really important. So the nerve is the one structure which is very sensitive to pressure, and anything which increases the volume of this tunnel, that is maybe any simple cyst like a lipoma or a ganglion or a flexor tenosynovitis, will cause increase in the pressure, will reduce the space of the tunnel, and will cause a carpal tunnel syndrome. So a ganglion, like a compound Palmer ganglion, or any sort of an a cyst, a tumor can cause a tenosynovitis, can cause any bony abnormality. You can see the floor is formed by the bone. And if there's any bony spicule or any malunion or any kind of an osteophyte which is coming from below or from the side of the scaphoid or hamate, it is going to compress that volume. It is going to reduce the volume of the tunnel, and eventually it is going to have a pressure on the nerve, and that is lead to carpal tunnel syndrome. Any situation like there's a fluid retention in the body, and which happens in pregnancy, hypothyroidism, or any other medical illnesses which may cause fluid retention in the body, can also increase the volume and cause symptoms of the carpal tunnel. So it's really pretty much straightforward that what can cause a carpal tunnel syndrome. And once the nerve is compressed at that levels, what affects is our intrinsic muscles of the hand. So intrinsic muscles, I mean to say the muscles which originate in the hand and are inserted in the hand, and they are the small muscles which basically have thenar and hypothenar muscles, the thumb and this side of our hand. So these thumb muscles are again supplied by the carpal tunnel beyond this, by the median nerve, sorry, beyond the carpal tunnel, which is the recurrent motor branch, which supplies the important muscles of the thumb. So if there's a chronic compression, these muscles start getting wasting, the muscles start to atrophy. There's an ape thumb deformity, and there's weakness of a position mainly, and there's also weakness of the grip. So that is the import. Apart from the pain and numbness and tingling and the other sensory symptoms which the nerve develops, it also has a long-term effect on muscle, and it causes muscle paralysis, which is usually irreversible if it is a long-standing compression. So the importance is that these muscles are have this. It has an effect directly on this, and you can see there's a normal thenar eminence, and then there's a thenar atrophy. Once you see a patient with a thenar atrophy, you have to assume that this has been a long-standing compression, and it is a challenging case to treat in terms of getting back the grip and the function of the thumb back. So now, which are the patients who are at risk of developing carpal tunnel syndrome? Like I mentioned earlier, that there are some differential diagnoses you have to keep in mind when you are seeing a patient of carpal tunnel, and you have to have something in the mind that it can be a cervical radiculopathy, which is a similar pattern of a pain coming from the neck into the arm and hand. And it can be something, it can be an inflammation in the brachial plexus sometimes, which can cause uh, the neuritis of the brachial plexus, and then have a typical pattern of nerve with radicular pain again. And also it can be anything, Pancoast's tumor, which is in upper pathology of the lump, apex of the lump. So a differential diagnosis is very important, and so is this slide, which says that risk factors. You should know which patients are at risk of developing a carpal tunnel syndrome, because it's to my practice, and if you ask any hand surgeon, the diagnosis of carpal tunnel is clinical. It's not EMG and CV, it's not ultrasound, it's not MRI, it's not X-rays. It's the clinical diagnosis, and that's what is even now. Even if we do EMG and CV, I'll come to that later on, but that's just to support your diagnosis. If you have to have your diagnosis before sending a patient to any EMG. So that will come to later on. So coming to the risk factors, I think 6 out of 10 patients are females. We've seen it's common in females. It's common in hypothyroidism, because I think that indirectly has a fluid retention in the body, and that causes the symptoms. Uh, Obesity is one of the risk factors. Pregnancy, I've mentioned earlier, again, it's usually temporary, which settles down after the delivery, or sometimes it's pretty bad, and we do have to do a release during peri-pregnancy, time. But yeah, it's very common in pregnancy. Rheumatoid arthritis patients have typically deformities in the hand. Their carpal bones, metacarpals, and joints are a bit uh, disorganized to some extent, and there are deformities, and that causes the uh, carpal tunnel syndrome. And also, they have, apart from the joint deformity, they have tenosynovitis, which is extensive in many patients, and that causes increase in the volume of the tunnel. There's a lot of swelling around, and that causes the carpal tunnel syndrome. Apparent anatomy. There are cases which have been reported that any abnormal anatomy of any structures, soft tissue structures, and maybe vessels and abnormal vessels are there sometimes, crossing the nerve on top, and we see it intraoperatively sometimes while doing a release that there's an abnormal structure, which is kind of causing a compression on top of the nerve. Apparent vessels anatomy is not very uncommon. Yeah, it is there. And chronic renal failure, mucopolysaccharidosis, mucolipidosis, these are all systemic conditions which causes a fluid retention and indirectly carpal tunnel syndrome. Smoking, alcoholism has been reported to have a risk factor in developing carpal tunnel syndrome. And the last and the most important, what we see is repetitive motion activity, which we are seeing now in our day-to-day practice, that there's absolutely no risk factor. There is no arthritis, there's no pregnancy, there's no hypothyroid, there's a male patient, and there's a severe carpal tunnel syndrome. So that is attributed to repetitive motion activities. Those who have repetitive motion of the wrist, maybe typing, maybe being on the computer for a long time, or any other occupation which involves the movement of the wrist, and they definitely do develop carpal tunnel syndrome, which requires some treatment. So these are to be kept in mind because this is an important slide, and you have this always at the back of your mind when you are treating a patient of carpal tunnel syndrome. Diagnosis, like I mentioned, is always clinical, and I please rely, and I tell all my fellows, residents, and everybody that this is something which you need to diagnose clinically, and you don't send patients to do MRI, ultrasound. We've seen patients coming with MRI of the spine, wrist, hand, ultrasound, EMG, NCV, and what not for the diagnosis of carpal tunnel syndrome. It was always, and it is always going to remain a clinical diagnosis. And if you are in doubt, if you want to rule out some other thing, you go for investigations. Nocturnal acroparesthesia, you have to ask leading questions to the patient. That how is the pattern of your pain? Is it disturbing your sleep? Is it more in the night? And you will get those answers, and which will tell you that yeah, it's kind of a hinting towards carpal tunnel syndrome. Then you rule out the other differentials like cervical spine and other compression neuropathies and whatnot, and then you will surely come to the diagnosis of carpal tunnel syndrome. So the pain is more on the radial 3.5 digits. We all know that distribution of the median nerve, sorry. So numbness, weakness of grip, and loss of dexterity, which is, holding of objects and falling of objects kind of. So that happens in chronic cases, of course, but in acute situation, it's numbness and pain, which is more at night disturbing the sleep. They may have radiating pain, which is going towards the upper arm and the shoulder, and they'll tell you that there's neck pain, and some patient may tell you there's neck pain and going down. So it's you who has to dig into the history and complaints and symptomatology, and then get the right answers from that patient, and which will take you to your diagnosis. So that's a clinical diagnosis. Clinical tests, of course, gold standard. They are age-old tests: Fallon, Steenel-Sign, Durkan test, compression test. They've been there for decades, and they are still gold standard, and they are still, very much applicable and very specific and sensitive tests. I'll not go to very much details about the tests, how we do them, but most of us know that, a Fallon's test by keeping your elbow extended, keeping your wrist palmar flexed, and then for 30 seconds you have to wait and see that if the patient redevelops those symptoms and signs. And then Tinel sign is tapping on the nerve, and that also gives. And however, the most sensitive and specific test, if you come clinically to see clinically, is the Turkin test, which was published in 1991 in JBS. So it's around 20 years back, to 30 years back. So compression, direct compression over the nerve causes symptoms, and a lot of studies have now, very well established, concluded that the compression test is the most sensitive and the most specific test uh, to diagnose carpal tunnel syndrome, even better than your EMG, NCV, and other tests. So try to examine the patient properly and do those clinical tests, and you'll come to the diagnosis. So the other thing is the differential diagnosis, which I mentioned earlier. Always try to rule out and look for any other pathology. A cervical radiculopathy is very, very commonly associated with carpal tunnel syndrome, and we call it a double crush syndrome. And there's a compression at two places, that is the cervical disc, maybe C5, C6, or C6, C7, and then at the same time there's a carpal tunnel syndrome. So you have to clinically examine the patient and figure out that which is the culprit, the wrist or the neck. And most of the time, when you see double crush syndrome, the main culprit is in the hand, which has been proven, and that is the radicular pain. They'll tell you that pain goes up to the neck. Thoracic outlet syndrome, I told you earlier, I'm not repeating that. So that Pancoats tumor is something which is a tumor of the apex of the lung, very rare. No, but yeah, just to complete the list of differential diagnosis, that is, I think, the inflammation of the brachial plexus, that Parsonage-Turner syndrome will go higher in the list, and Pancoast tumor will be in the last. So that is at least cervical radiculopathy and thoracic outlet syndrome is a commoner differential diagnosis. There are simpler tests to rule out those conditions, and you can quickly do a Roos test for thoracic outlet, Adson's test, and then you rule out that, yeah, we're not dealing with thoracic outlet syndrome. And coming to investigations, personally, I always reckon that try to be sure that you already have a diagnosis before doing any investigations. And so the goals are to see, it's not that it will not give you any information at all. It will surely give you information about the location of the lesion, whether it's involving the motor, sensory, or both, whether it's axonal loss or it's a demyelination, a severity of the lesion, mild, moderate, severe, and time roughly, how old it is. So it gives a lot of information, more than what we have clinically. It may not change the treatment at all. The treatment may be either conservative or surgical, which remains the same, but then it gives an idea that it has, variation. You can explain it to the patient that you have certain things, it's long-standing. But then, like I told earlier, that treatment may not change even after you have done these tests. So on basis of the electrodiagnostic studies, two things are important, which we see. This is more of a theoretical than a clinical part. Is we see two things: sensory nerve fiber compression and motor nerve fiber compression, and there are certain guidelines and values. If there's a distal sensory nerve potential greater than 3.4 and motor more than 4.2, that is the diagnostic criteria on diagnosing the carpal tunnel syndrome. On these two things, I think what is more important to this is this slide, which we have to categorize the patients into mild, moderate, or severe, because this is important, and this is again clinical. Of course, EMG and CV will tell you that whether it's mild, moderate, or severe. They'll label it in the report. Sometimes they will not, but you should clinically again be able to diagnose whether it's a mild. Once you've diagnosed, it's a CTS. We are dealing with carpal tunnel. Whether it's mild, moderate, or severe, we have to diagnose it. Label it so that your treatment becomes easy and you know what to do. So when is it mild to moderate? When there's no muscle atrophy, no muscle weakness, absent denervation, and mild abnormality in EDS. So very simple. No atrophy, no muscle weakness, EMG NCV is mild. It goes into mild. When there's muscle atrophy, muscle weakness, EMG NCV shows severe change. Mild to moderate, you can go for conservative treatment. When there's severe, you go for surgical treatment. It may not hold true for all. We've been doing surgery sometimes in mild to moderate as well, but they have very severe symptoms. The pain is so much, then there's no sleep, conservative is not really working. They are good candidates for surgery. Severe, of course, are. Non-surgical methods will work good in mild to moderate, which we just mentioned earlier. Splints, braces, ultrasound therapy, laser therapy, NSAIDs, steroids, local injection in the carpal tunnel, workplace modifications, nerve glide exercises, works brilliantly, I must say. I think 80 to 90% of the patients who are pretty bad at presentation respond very well to non-surgical treatment, and they will never ever require a surgery. Intra-articular injection, very good modality. It gives an excellent relief. It has been proven, and it has been people have various studies. People are doing it. Even I personally do it sometimes in it's a small set of patients. And it also gives us a clearer idea that if a patient has a good relief and if he returns back with the symptoms after a few months or years, that surgical treatment will definitely have a good result on that patient. So this is a very good one modality, middle path between non-surgical and surgical to give an injection and OPD procedure, and patient has a very good relief of symptoms. So the question comes when to do a surgery now. Like again, I've mentioned earlier, the severe cases will need surgery. And the mild cases with persistent numbness and pain after a trial of conservative treatment, which usually 6 weeks, you can't let a patient, take steroids orally, take a lot of medications and on for months together. That's not the right idea. Again, you need to do a surgery in certain patients, and that really helps them. Motor dysfunction, when you start realizing the patient has weakness of grip, pinch, grasp, there's some flattening of the thenar eminence, you know that this is not going to stop and it needs a surgery. Thenar flattening, so severe nerve entrapment in electrodiagnostic studies to add to that. One of the relative indication is after distal radius fracture fixation, there has been incidents, and we have done a few cases of release in the immediate post-op when there's a fixation of the fracture done, probably related to the implant, a different topic altogether. So it's important. It is very important to know that surgery may be effective even if the patient has normal nerve conduction. Studies which has been again published in Journal of Fan Surgery, British, in 2008, that sometimes we see a patient, I have seen it, and all of us have seen it, that a severe symptoms of carpal tunnel syndrome and a normal EMG and CV report. So that's why I always insist not to completely rely on the reports. Now coming on to surgery quickly. Surgery is two types, endoscopic or open. A lot of literature on both, whether to do an endoscopic surgery, whether to do an open surgery and stuff like that. But what I must tell you on the beginning of this slide is that the long-term results of endoscopic and open surgery are exactly same. And long term, I mean, is 6 months. After 6 months, if you see both the group of patients, both have the same function, both do excellent, and the difference is the initial 2 months, which is very good with endoscopic, and which is the patients with carpal tunnel have the issues of the scar, which is initial 2 months. So this has been proven in various studies. Endoscopic quickly, there's a single portal technique. What we do usually is a single portal technique, and there's a twin portal technique, which I think hardly anybody is doing now. Quickly, if I go to this video, is you make a small incision in the proximal part of the wrist, which is a transverse incision and in a not on the palm, so that that scar is not there. You go under the tunnel, you cut the ligament, and that is how you that's how the release is done. So that's the arthroscopic endoscopic views. That's the triangular blade basically, which goes underneath. That's the white thing is the transverse carpal ligament, and you hook it and you retrograde. You cut it with a knife, and that's now open carpal tunnel release. You do certain markings. These are very important um, to locate the tunnel so that you have your incision on the right spot. You This is known as a Kaplan's line, a very important line in the surface markings of the hand. And then you mark your ring finger, you mark that point, and then you mark the incision, and then you take the incision, skin subcutaneous tissue, and you go on the undersurface of the tunnel. You behind you see is the that's the median nerve. You distal part of the forearm. You release the fascia, and then you do the. This was a case in which the distal radius fracture was fixed, and he had a because of the implant. That's what I was mentioning earlier. So important. Every surgery has its own complications, and the important dangers. One has to know what are the important dangers which can be there. So palmar-cutaneous branch of the median nerve, it can cause hypoesthesia. That's again a disabling problem. It lies between the palmaris longus and FCR. So try to avoid that. Don't damage that. Recurrent motor branch is the most important branch which supplies the thenar muscles. So you have to take care of that. So 50% time it's extra ligamentous, it can be subligamentous, transligamentous. So whenever we are doing an incision, we're taking an incision inside the transverse carpal ligament. Try to be on the ulnar side as much as possible, so that your chances of damaging the recurrent motor branch becomes very less. Every surgery has its own complications. We know that injury to recurrent branch, palmar-cutaneous branch, scarring, laceration of the superficial palmar arch. If you go more distally, you can damage the superficial palmar arch, which leads to a lot of bleeding, and intraoperatively you can have you can mess it around. And tendon adhesions, surgical site infections, of course, very rare. Hematoma sometimes does happen. Yeah, if you have lacerated the palmar arch and you've closed it and then release the tourniquet later on, and you realize that there's a hematoma which is formed. Stiffness. We've seen patients developing Studex's dystrophy and stuff like that after carpal tunnel. So yeah, try to get them moving as early as possible. Revision carpal tunnel syndrome is not uncommon. We've done many, and the most commonest cause of revision is incomplete release. That is surprisingly, it is the commonest cause of a revision surgery in a carpal tunnel syndrome. So when you've taken an incision, make sure you completely released it from inside. There's a landmark like when you see a distal fat pad sign, that means your distal release is complete. Proximally, the peroneal fascia, the fascia of the distal part of the forearm, has to be released so that the release is all the way and there's no recurrence. Prevention, important. Avoid stress on the wrist, proper posture, exercising to strengthen the fingers, nutrition, avoid smoking, alcohol intake. These are the things which can prevent. Thank you.
Yeah. Thank you, sir. That truly has been a very enlightening talk. I think you really highlighted right from the anatomy. I mean, you took us through the entire course. So, highlighting the risk factors, looking into the causes, looking into the diagnosis, even, including the electrodiagnosis and what would help to kind of decide whether surgery would help or not, and what would be the advantages or disadvantages of an open versus endoscopic. And even the recent evidence and literature, which tells you that, the 6 month long-term follow-up was almost
Okay.
similar for both the surgeries. So all in all, I think all of us have gained a lot from this lecture. And
Thank you.
thanks a lot, sir.
Thank
And
you.
we'll be soon followed by a talk on the physiotherapy aspect of carpal tunnel
Sure, sure,
syndrome.
sure. Yeah.
And follow